All right, let's talk about one of the most intense situations you can face in medicine, a patient who simply cannot breathe. In those moments, it feels like chaos, but having a solid game plan, well, that's what saves a life. Let's get right into it.
So, picture this. The monitors are screaming, your patient is struggling, fighting for every single breath, and all eyes are on you. Your ability to cut through the noise and make the right call right now is everything. This isn't just academic. We're talking about those critical seconds that make all the difference. So to make sense of that chaos, we're going to break it down into 5 key parts. First, the universal steps you always take. Then, we'll tackle obstructed airways like asthma and COPD. Then, a collapsed lung. Then, a couple of key infections. And we'll wrap up with that great masquerader, the pulmonary embolism. All right, let's kick things off with section 1. Think of these as your foundation. These are the moves you make right away, before you even know exactly what's going on. Get this part right, and you're already setting your patient up to win.
You know, we all get the ABCs drilled into us: airway, breathing, circulation. But here's a super important little twist for someone in real respiratory distress. While airway is always key, B for breathing often becomes your immediate #1 priority. You have to fix the oxygen problem, like yesterday.
So what's your absolute #1 move before pretty much anything else? Get that patient on supplemental oxygen. That's it. It's the single most important thing you can do because it buys you precious time to figure out what's really happening underneath. Okay, so now that we've got our foundation, let's build on it with section 2. We're talking about obstructive diseases. You hear a wheeze and you might think it's straightforward, right? But the way you manage a severe asthma attack versus a COPD flare-up, they have some critical differences you absolutely cannot get wrong.
And this table, wow, it just lays it all out. Look at those oxygen targets. For asthma, you're pushing for a normal oxygen saturation, 94 to 98%. But for a COPD patient, you're actually aiming lower, 88 to 92%. Why? Because you want to avoid knocking out their drive to breathe. That one little detail, it's a total game changer. And look at the other tools. IV magnesium is huge for tough asthma cases, while BiPAP is an absolute go-to for COPD.
For asthma, you have got to be on high alert for these signs of a life-threatening attack. A silent chest is just terrifying. It means so little air is moving, you can't even hear a wheeze. But the most sneaky, dangerous sign on this list, a normal carbon dioxide level. Think about it. A patient this sick should be breathing super fast, blowing off all their CO2. If it's normal, it means they're exhausted. They're about to stop breathing. That's a 5-alarm fire.
So, the second you spot those red flags, this is your playbook. You gotta move fast. First, high-flow oxygen. Then you hit them hard with back-to-back nebulizers. Get systemic steroids in them early. They take a while to work, so you want them on board ASAP. Then you layer on another medication, ipratropium, and if they're still not getting better, you're thinking about IV magnesium.
All right, let's switch gears. We're moving from a problem inside the airways to a straight-up mechanical problem, a collapsed lung. And in this situation, everything comes down to answering one single vital question.
And this right here is the $1,000,000 question you have to answer, and you have to answer it fast. Is this just a simple collapsed lung, or has it turned into a life-threatening tension pneumothorax? One is serious, the other will kill your patient in minutes if you don't act.
So how do you tell the difference? Well, this is a clinical diagnosis. You cannot, I repeat, cannot wait for an X-ray. Your patient will be in agony, struggling to breathe. You'll hear no breath sounds on one side of their chest. And the huge clue? Their blood pressure will be in the tank. That's obstructive shock. The pressure in the chest is so high, it's crushing the heart and blood vessels. That tracheal deviation thing? Yeah, that's a classic sign. But by the time you see it, you might be too late. The second you make that call clinically, you have to act. No hesitation. Step 1 is immediate needle decompression. You take a big needle, you put it in the second intercostal space, right in the mid-clavicular line, and you should hear this satisfying hiss of air escaping. But listen, that's just a Band-Aid. It buys you time. You have to immediately follow it up with step 2, the definitive fix, putting in a proper chest tube.
Okay, up next, let's dive into the infectious stuff. We're talking pneumonia and tuberculosis. Now, at first glance, they can look kind of similar, right? Both can give you a nasty cough and a scary-looking chest x-ray. But in the emergency department, your priorities for each are completely different.
And this really gets to the heart of it. The way you approach these two is just worlds apart. With pneumonia, you are in attack mode. It's an acute infection, and your job is to get on top of it, fast. But with TB, that's a chronic disease. In the ED, your job isn't so much about starting treatment as it is about identifying the patient and, crucially, isolating them so they don't infect anyone else.
So with pneumonia, especially if that patient looks septic, that 1-hour clock starts ticking loudly. The goal is to get powerful, broad-spectrum IV antibiotics into that patient within 1 hour. There's a reason this is a huge quality measure. It saves lives, plain and simple.
Now, flip that coin over and look at TB. This quote says it all. Because it's a chronic illness, you don't need to start the complicated multi-drug TB treatment right there in the ED. That's a job for the specialists later. Your job is to put on a mask, put the patient in a negative pressure room, and get the right tests going.
And that brings us to our final section, number 5, the one, the only, great masquerader, the pulmonary embolism. They call it that for a reason. It can present in so many weird ways, making it an incredibly tricky diagnosis to pin down.
But this is one of those things where you have to keep your suspicions super high. The classic combination you're looking for is a patient who suddenly gets chest pain that's worse when they breathe in, along with shortness of breath and low oxygen levels. When you see that trio without another obvious reason, PE has to shoot to the top of your list. So once PE is on your radar, your entire game plan, everything you do next boils down to one simple question. Is the patient stable or unstable? And really that just means, what's their blood pressure? If it's normal, they're stable. If they're hypotensive and in shock, they're unstable. This is the critical fork in the road. And that's because the treatments are, they're night and day. For the stable patient, you start anticoagulation, blood thinners, to stop that clot from getting any bigger. But for the unstable patient with a massive PE, you bring out the big guns, thrombolyses. These are clot-busting drugs designed to dissolve the clot and save their life. So let's leave you with this final thought. Attention pneumothorax, a massive PE, a crushing asthma attack. They can all walk in the door with chest pain and terrifying shortness of breath. Each one is a stone-cold killer, and each one requires a completely different move from you. So what's your move? Which killer do you hunt down first? Answering that question in the heat of the moment, that's what this is all about.